So yeah, so this is for the Trident Academy lecture. So yeah, so this is basically going to be a talk on infective endocarditis and the questions the undergraduates get on this topic. Okay, so we'll straight away move on to the lecture. Yeah, so I thought of making this as a question and answer session so that it would be more interactive and it would be more palatable rather than just a theory session. So first thing is the talk is on infective endocarditis. So any topic, the first question you should ask yourself is what is that? What is meant by infective endocarditis? Okay. So I won't ask you this question because this would be the least question, the least common question that can be ever asked uh, in an exam. So exam point of view, it's very unlikely anyone would ask you what is infective endocarditis or define infective endocarditis, but it's always nice to know what that condition is. So infective endocarditis is basically infection of the endocardial surface of the heart valves and also large vessels, not only the valves, the vessels, and also it might be the infection of an intracardiac device. So the common mistake we make is, or the common myth is, it's only the infection of the valve. No, a large vessel, any endocardial surface of the cardiac structure can get infected. Okay, it may be a large vessel, it may be an intracardiac device. So it's basically an infection of the endocardial surface of the heart valve or vessel or a device. So that's it, nothing more. And the second is, what are the risk factors for infective endocarditis? Of course, this appears at your, third year level, or final years also, and even sometimes in the MD exam also, you are questioned. So I forgot to tell you now, when infective endocarditis is considered, it will come for your MCQs as a true false question or SBA, and for your long cases or observed history taking, and also it's needed for you to practice in your wards, isn't it? At the end of the day, you might say patients with infective endocarditis as when you are practicing as intern. Okay? So it's an important topic. So this is a famous question by a prof attached to, National Hospital. So, and also it is a famous question in the MRCP and even the undergraduate exams. If you go through the pool of questions, you will get to know. The commonest risk factor for infective endocarditis is nothing other than the previous infection. So previous history of infective endocarditis is more than enough to be a risk factor. Okay. So don't forget it. That is the commonest risk factors. There are the other risk factors. The others are the valvular heart disease. And usually it might be difficult for you to memorize, but certain questions are targeted on these. When you have a high pressure jet, so that jet would hit the endocardium and damage it. So the easy way is, whatever the valvular condition or any congenital heart defects which gives rise to a high pressure jet, that would cause or predispose to infective endocarditis. For example, MR, AR, they produce a jet, and VSD, they produce a jet. So they are more prone to get infective endocarditis. If you have those lesions, you are at a risk of infective endocarditis. Having said that, it's again a famous question. What about ASD? Compared to VSD, ASD doesn't produce a high pressure jet. So the chance of you acquiring infective endocarditis on top of an ASD is very less. Okay, I won't say it's zero, but it's very less. So this is also tested in the exams commonly. The other thing is congenital heart defect. You all know tough Eisenmenger, the common adult medical cardiac conditions you will encounter, the two cyanotic heart diseases, okay, and the other congenital heart diseases we spoke about, and intracardiac devices, cardiac surgeries, and then come the poor dental hygiene. So there will be questions if you go through the undergraduate curriculum questions. There will be questions. There will be, either in your cardiac module, undergraduate exams, or any exams. So relating a condition to the organism. So if you have poor dental hygiene, you get those a group of viridans and the other Streptococcus malaria and other groups and some anaerobic bacteria causing infective endocarditis. Okay, so that's why those days when you suspect infective endocarditis, they used to ask about the dental hygiene. And those days, viridans used to be the predominant organism, not anymore. Now, staph is the commonest organism for infective endocarditis. We'll come to that later. So, poor dental hygiene is important. So, in your long case, also make sure that you ask about the dental hygiene, dental procedures, anything. And prolonged urinary catheter in an elderly person. it predisposes a person to get enterococcal infective endocarditis. So this is also frequently questioned. And IV cannula insertion and IV drug use. So a patient who has had a cannula coming with prolonged fever, or IV drug user coming with prolonged fever and a murmur, you would suspect an infective endocarditis. So these sort of people, IV cannulas or drug abusers, do get staph endocarditis, and usually the staph endocarditis affects tricuspid valve. So they present with tricuspid regurgitation. Okay. So this is also tested in the exams very commonly. Usually mitral valve is the commonest valve affected by infective endocarditis overall. Then comes the aortic valve. But these IV drug users have a predilection to get tricuspid valve endocarditis. Don't forget it. Okay. And bowel malignancies. So bowel malignancies predispose a person to get Streptococcus bovis infections. Okay. So Streptococcus bovis infections are very common with bowel malignancies. Okay. Some people do say that it's Galolyticus. So I mean the names vary, but that is also commonly questioned. And yeah, there's a printing mistake. Sorry about that. Male sex and old age are also risk factors. You could forget it. So risk factors is an important thing when it is concerned to the exams. So you have to know the risk factors in and out. No question at all. Then now it comes a question, why don't you and me get infective endocarditis? But someone else, see, how many patients do we cannulate? How many patients do have these rheumatic heart diseases, congenital heart diseases? But why don't all of them get infective endocarditis, isn't it? So yeah, so it's basically the pathogenesis differs. So in a patient who has a susceptible cardiac lesion, as I told you earlier, a high pressure jet producing lesion like MR, so you get a damage to the endocardia. And along with that, if you have a risk factor for bacteremia, say that you have a wound, or you have a UTI, or you have a cannula where the bacteria can go in or get access to the circulation, then they can go and colonize that damaged endocardium, because damaged endocardium has less protection against bacteria. So initially a sterile plated fibrin nidus. So when you get when the endocardium is damaged via the pressure jet, you get a plated fibrin clot, or a nidus, and then that plated fibrin clot or the nidus will get infected with whatever the organism which is circulating in the circulation. So during the bacteremia. So this is the way infective endocarditis is formed. So this pathogenesis part is usually applicable for a subacute or chronic variant of infective endocarditis. So in a valve damage plus bacteremia. So those are the two chunks, valve damage and bacteremia. But having said that, there is another variant called acute infective endocarditis, where certain people do get infective endocarditis with normal valves, no predisposing conditions. We'll come to that later. Okay. Yeah. So what are the typical organisms causing IE? Again, Staphylococcus aureus. Nowadays, the commonest organism causing infective endocarditis is Staphylococcus aureus. This used to be a famous question. When I was a medical student, the answer was viridans streptococci. So it used to appear very commonly in the paper. Okay, that's it. That is then again coagulase positive Staph. So Staph aureus is the commonest one. So what are the risk factors for Staph aureus infections? IV cannula, drug use, blah blah blah. And Staphylococcus epidermidis, coagulase negative, also can cause infective endocarditis, especially in people who have had prosthetic valves. So within first 2 months of cardiac surgery or prosthetic valve surgery, you are more prone to get infective endocarditis with Staph epidermidis. Okay, that duration is important. Within 2 months, less than 2 months, 60 days. Okay, and Streptococcus viridans, the previous zero, was the commonest one that occurs with poor dental hygiene, and Streptococcus bovis, as I told you earlier, colorectal cancer, and Streptococcus mitis again from dental work and stuff. This is basically to demonstrate the valve, the vegetations and stuff. And there is, as I mentioned earlier in the pathogenesis, what are the types of infective endocarditis? There are two types. One is, there's a two way of classifying. One is from the type of valve, native valve infective endocarditis and prosthetic valve infective endocarditis. Why do we classify that? That is because the management, the organisms differ from native valve to prosthetic valve. So that is the reason we have to classify that as native and prosthetic valve. Okay. And there is this acute infective endocarditis versus subacute or chronic infective endocarditis. Okay, so acute infective endocarditis, as I mentioned earlier, it occurs with a normal valve, a person with a normal valve due to a highly virulent organism. So it's usually a staph endocarditis. If you go and read Davidson, you would see a nice chart mentioning about acute and chronic. This is also commonly asked. So acute endocarditis, it's staph in a normal valve. Okay, it's a virulent organism. And subacute or chronic is more or less the same. You have a predisposing valve lesion and you get colonized with the other bacteria and you get infective endocarditis. Understood so far? Any doubts? So what would be the commonest valve lesion predisposing to infective endocarditis in IV drug users? Anyone? Hello? Did I put you to sleep? Whom should I ask? Yamini, are you sleeping or are you awake? Yamani? Hello? Okay. The usual suspect.
Acute infective.
Yeah, what sort of an infective endocarditis, what sort of a valve would get affected in IV drug user?
Tricuspid valve affected.
Yeah, good. Yeah, so I mean, then it's usually you get with regurgitation, tricuspid regurgitation. Usually the valve damage will cause regurgitation. The other thing clinically which is important is usually when you get for severe short cases, so all these regurgitation murmurs, you can say infective endocarditis is a etiology. Okay, MR, AR, when they ask what could be the possibilities, you can say, but usually they don't cause stenotic murmurs. Okay, so that's not very common. So usually it's a regurgitant murmur, TR, MR, and AR. Okay. And now the main question, now we spoke about infective endocarditis. Now, how do they present? Okay, or in the other words, what are the clinical manifestation? Nadun, have you seen infective endocarditis patients?
Yes, sir.
How do they present? How?
With mainly symptoms, fever, and generalized malaise, and
Yeah, good. So the commonest symptom is fever. Okay, that's again a common MCQ. So commonest symptom is fever. It could be high grade or low grade depending on the type of infective endocarditis. Okay, it might be a low grade fever or high grade fever. You can't be sure, and there might be constitutional symptoms, loss of weight, loss of appetite. But having said that, infective endocarditis patient might not have fever at all. Absence of fever doesn't exclude it. Okay, mind you, it won't exclude it. Okay. And I mean, it could be a various presentation. I mean, one is fever, constitutional symptoms, and it could be due to, I mean, embolic phenomena. Okay, so you can get various septic emboli. These splinter hemorrhages, petechiae, and you can get splenomegaly. Okay, and there are these immune mechanisms where you can get these glomerulonephritis, or you can get hematuria. So these are basically the intracerebral pathology what happens in infective endocarditis. Say if you get a septic emboli, you can get an embolic stroke. When the septic emboli with an organism damages the blood vessel, there will be mycotic aneurysm formation. And if the mycotic aneurysm ruptures, you can get intracerebral hemorrhage or SAH. So these are all asked in the MCQs in the past. Okay. So stroke, stroke, mycotic aneurysm, ICH, SAH, multiple cerebral abscesses in the MCA territory. So these are all possible. So this is a favorite area of question when it comes to exams. Okay. And again, these rock spots, basically retinal hemorrhages with pale center. Okay. And there are these Janeway lesions. You know how to identify in the cases. You look for that. They are non-tender macules on palms and soles. And I mean, splinter hemorrhages are not specific. And Osler's node, they are tender nodules in the pulps. So they are immune manifestations. Okay. So basically, I wanted to put it, I forgot it. So there are these embolic phenomena, these petechial hemorrhages, rock spot. I mean, those are mainly due to septic emboli, but certain immune manifestations are there due to infective endocarditis. For example, you can get glomerulonephritis. You can get rheumatoid factor positivity. Okay. and you can get Osler's notes. Those are due to immune phenomena. So your immune system forms complexes and they cause these immune phenomena. Whereas this Janeway lesions, rock spots are due to septic embolic phenomena. Okay, so that you should know. That would come in the, don't worry, that would come in the criteria as well. So now, as Nadun told, a patient comes with prolonged fever, we suspect infective endocarditis. How do we proceed? How do we investigate? Okay, this is again asked commonly in the long cases when you have a PUO case. I mean, we do give PU as a long case. So blood cultures are the cornerstone of diagnosis of IE. So that comes for a, I mean, yeah, the other thing is you get best choice questions as well. So there is no single investigation to, mind you, there is no single investigation to diagnose infective endocarditis. Blood culture will show there is a septicemia, and echo will show there is a vegetation or cardiac imaging. So basically we combine both together. So blood cultures are a cornerstone of microbiological diagnosis. So how do you draw the blood pressure? It's a famous question in the long case or the OSCE Viva. So you have to draw three sets, okay? And each set should consist an anaerobic and aerobic bottle. So this yields a high sensitivity. Why don't we take 2 and why don't we take 4? Because 4 is just you puncture. That's not going to increase the sensitivity because it is already 96 to 98. There's no point in taking 4 sets. It's unnecessary waste of prick time and resource. 2, if you take 2 cultures, there's a high chance you might mix the bacteriemia because some of these bacteremia may be focal and transient, episodic. That's why sometimes they do take cultures after 12 hours. Neither because of the fact that some of these bacteremia are episodic. Okay, so basically you target for 3 sets and at least try to get 1 set from the central line. I mean, femoral puncture would be better, but at least 3 sets, 1 aerobic and maker. Okay. And how do we diagnose then? Okay, now, is there a criteria or how do we diagnose? We can do full blood counts, ERPs, creates, UFRs, echoes, cultures, but is there a way of diagnosing? Yeah, what we do is we use modified Duke criteria to diagnose infective endocarditis. Duke is the person who proposed the diagnostic criteria initially, then we made changes over the years and now it's modified Duke's. So when we were medical students, there was not much emphasis on pathological criteria. We had only major criteria, minor, and those stuff. But there's now a pathological criteria. Say that infective endocarditis patient dies or he undergoes a surgery where you can demonstrate or culture the organism in the valve, or you can show the vegetation or embolic fragments pathologically. That is confirmatory of infective endocarditis. You don't need to have anything else. Okay, so one pathological criteria is more than enough to diagnose endocarditis. But this doesn't happen. I mean, yeah, patients do die, but we don't wait until they die to confirm infective endocarditis, isn't it? It's not very practical. Theoretically, yes. So practically, we use major criteria. One is a positive blood culture. I mean, 3 sets, we spoke about it. So if you have a blood culture for a typical organism, the typical organisms are staph, strips, I mean the viridans and the endococci, and this HAECK group. So what is this HAECK group, or what you know about HAECK group? So these are all gram-negative organisms. One of the famous question in the Colombo faculty time was, what are these HAEC groups? They are gram-negatives, okay? Haemophilus, Cardiobacterium, Echinella, Kingiella, Acetino. So these are the HAECK. You don't need to know the full names of them, but know that they are gram negatives. And they are also classified under organism, typical organism. Though some people do say they are atypical, they also fall actually under the typical culture. Okay. And yeah, so blood culture positivity means either out of the 3, if you have 2 positive cultures, you call it bacteria blood culture positive for a typical organism. Or else, if you can't demonstrate that, if there's a persistent bacteremia from more than 2 cultures, that means 12 hours apart, you take cultures, and if it grows a particular organism, you can take it as blood culture positivity. So for you to call blood culture positivity, either 2 cultures should be positive for a typical organism out of 3, or persistent culture positivity for a pathogen. Or else certain organisms cannot be cultured. For example, Coxiella, Bartonella, Chlamydia, they can't be cultured. Okay, so if their serology is positive, you take it as a major criteria. And there are these new molecular assays, we don't need to know about that. That's too much. That's for the postgraduate trainees. So evidence of endocardial involvement. So this is also asked, what are the evidence or what would you expect to see in the echo? So usually, I mean, traditionally we use 2D transthoracic echo and transesophageal echo, which has high sensitivity. But nowadays there are evolving cardiac imaging modalities, cardiac MRI, PET scans, cardiac CT, so they can be also used. So what you expect to see is an oscillating structure in the attached to the valve, or an abscess formation, or new valvular regurgitation, a new murmur, or dehiscence of a prosthetic valve. So these are the evidence of infective endocarditis in the cardiac imaging. Oscillating structure or whatever, a pendular structure attached to the valve, abscess formation around the valve, a new valvular regurgitation, or a dehiscence, I mean the breakdown of a prosthetic valve. So, and it's important that a normal echo doesn't exclude infective endocarditis. What you do, if you suspect endocarditis, the echo is normal. Another you would have seen in the ward setting, we would ask for a TOE, transesophageal echocardiogram, because it's more sensitive. Because transthoracic has a sensitivity about 70, but this has more than 90, transesophageal. And the minor criteria, predisposing heart condition. So if you have a rheumatic heart condition, or if you are an intravenous drug user, you get 1 point. Or a microbiological evidence that doesn't meet the major criteria. What is that? So I told you one of the blood culture criteria was 2 out of 3 cultures should be positive for a typical organism. So if you grow, say for example, Pseudomonas in 2 cultures, can you take it as positive? No. According to this criteria, Pseudomonas being grown in the culture cannot be taken as positive. So that would get a 1 point under the minor criteria. But if you grow staph strep for viridans or HACK, you will get a major criteria. Do you understand that? Don't get confused. Okay. And fever more than 38 degree, that we know. And vascular phenomena, I was emphasizing on this. Vascular phenomena are major emboli, splenomegaly, clubbing, splinter hemorrhages, petechiae, or purpura. These are manifestations of infective endocarditis. These are the things we look for in examination when you are given a short case with MR or AR. And immunological phenomena, the mnemonic is GOR, glomerulonephritis, Osler's nodes, rock spots, and Janeway lesion. So these are all immune phenomena. Okay, this is basically a summary, as I told you. So at the end, how do you diagnose? If pathological criteria is present, that's fine. Or if you have 2 major criteria, you diagnose a definite infective endocarditis. Or if you have 1 major criteria and 3 minor, you can diagnose infective endocarditis. Or in the absence of major criteria or pathological criteria, if 5 minor criteria are present, you can diagnose infective endocarditis. This is basically again a summary. So having said that, again, the other important thing is sometimes you have valvular evidence of endocarditis. The CRPs are high, the patient would be running high spike of fever, but the culture doesn't grow anything. So there are these entity called culture negative endocarditis, again a famous exam topic. So what are the causes? Nadun, again, what are the causes for culture negative endocarditis? Nadun?
Yes.
So one thing is, if you have already treated the infection, sometimes you go to the GP, GP treats for UTI or respiratory infection. So partially treated bacterial endocarditis would be culture negative. Okay. And that is, infectious etiology. So I've divided it into 2, non-infectious and infectious. So culture negative causes due to infectious etiologies are prior antibiotic therapy. That's again a famous MCQ. And certain organisms cannot be cultured. Brucella, Bartonella, Coxiella typically cannot be cultured. That's why you go for Coxiella serology, 1:800 serology. And this hack, though, that's why I told some people do call it atypical, that's because of this factor. Sometimes the HACK cannot be cultured. The culture positivity of those organisms, the Haemophilus acinetobacter, Cardiobacter, and Echinella quintillae are very less. So these are gram negative, may be difficult to culture. So that might be a cause of culture negative endocarditis. This is a famous question. And there are non-infective endocarditis. So endocarditis may be due to non-infective causes as well. There are 2 types. One is non-bacterial thrombotic endocarditis. Okay. The other one is merantic endocarditis. So you need to know briefly about these conditions. So non-bacterial thrombotic endocarditis is usually asymptomatic, 50%. And it causes common embolic phenomena. If they present with embolic phenomenon. How? They present with strokes, they present with renal infarcts, that's how they present. But having said that, though they are non-infective, they can present with fever as well. Okay. At times it might be very difficult to differentiate non-bacterial thrombotic endocarditis from infective endocarditis. You can't say absence of fever, okay, this is non-bacterial. No, even infective may not have fever, and infective may have fever. Even non-bacterial thrombotic endocarditis may have fever, may not have fever, but usually they are asymptomatic, and the embolic phenomenon is very common with them. Okay. And then how do you make a diagnosis? So if you have a predisposing condition, and if the cultures and serology are negative, and if you have imaging evidence of endocarditis, then you call it non-thrombotic bacterial endocarditis. Okay. So there is a variant of non-bacterial thrombotic endocarditis called Libman-Sachs endocarditis. Okay. It's a variant. It commonly occurs in SLE patient. This surprisingly has a low embolic risk. Okay. Usually, non-bacterial thrombotic endocarditis has a high embolic risk, but whereas this Libman-Sachs variant in SLE has a less embolic risk. Understood? So, non-bacterial endocarditis is usually asymptomatic. You can't differentiate it from infective endocarditis. So, usually it occurs in connective tissue disorders like SLE, very rarely rheumatoid arthritis. And how do you diagnose it? You show vegetations in the echoes or imaging, but cultures of serology would be negative. Okay. Okay. Marantic endocarditis is simple. You get it in malignancies. Okay. That has also been questioned. So why do we talk much? Because the management is different for infective endocarditis and non-infective causes of endocarditis. That's why we keep on emphasizing. So now we come to a question. Now we know what is infective endocarditis, what is the pathogenesis, what are the risk factors, how do they present, how do you diagnose, and now we have to move to the important part, how do we treat? Okay, now you will get questions, or even my registrars ask me, what is the place of anticoagulant? Because we spoke that people can have strokes, gangrenes due to emboli. Do you give anticoagulant? Now, do we give antiplatelets and anticoagulant for infective endocarditis if they have stroke?
Not sure.
Yeah, this is a common make. So far it's usually not tested in the exams, fortunately. No, the answer is no. But if you remember your BNF, or that, what is that, Bennett and Brown, the pharmacology book. So what happens is anticoagulation is a relative contraindication for infective endocarditis. Why? Because as I told you, infective endocarditis can give rise to septic emboli, and you can have mycotic aneurysms. So there's a high chance when you give anticoagulation, you can have that aneurysm being ruptured and you can get an ICH. So this is commonly asked in the long cases. Even for MD graduates, they ask it. So stroke, you have a valve lesion, and if you suspect infective endocarditis, you don't give anticoagulation, or you don't even thrombolize, because there's a high chance of ICH and bleeding. Okay, understood? Okay, and we don't give antiplatelet as well, even if they are having gangrene. Okay, that is for infective endocarditis. But having said that, non-infective endocarditis, the mainstream of management is anticoagulation. Okay, that is a controversy there. So that is why we were concentrating more on these groupings. Infective and non-infective, because non-infective, the main say of treatment is anticoagulation. Okay, so then, okay, we spoke about the anticoagulation, antiplatelet controversy in infective endocarditis. So we don't give it. And what about antibiotics? So the mainstay is antibiotics. So we give IV antibiotics for a prolonged period of time, 4 to 6 weeks. Why do we need to give IV antibiotic for a prolonged duration? This is also a famous question in the long cases. So the valve is a relatively avascular structure, the valves. Okay, so it's very difficult for us to achieve a desired minimal inhibitory concentration. You would have learned about MIC in pharmacology. Okay, so it's very difficult. So to access that, and the organisms are very safe in the vegetation. They hide beneath the platelet and fibrin plugs. So for you to get a high concentration of antibiotic, you will have to give IV, high doses for a prolonged period. Okay. So now, what is antibiotic we give? So that is a problem, no? Now, what do we give? So if it is a native valve infective endocarditis, in initial empirical treatment, that means in the ward setting, no one will come and say, hi, I have a staph endocarditis, because the cultures will take time. Okay, you can get the echo done. So you suspect infective endocarditis, you have to start antibiotics urgently, because after taking cultures, you won't wait for the culture result. Okay, that's the other thing. You take cultures, infective endocarditis, what do you do? That's a base. That's a fundamental management. A person who comes with prolonged fever, valvular regurgitation, murmur, you suspect infective endocarditis. Okay, the next best step is do a culture, do those 3 cultures, arrange an echo, start antibiotic. This is the order. You don't start antibiotic and take culture. And you don't take culture and wait for the results. Okay, these are all asked in the best choices. So you do a blood culture, echo, start antibiotic before the results come, and then later, depending on the organism, you can change. But until that results are available, how do you go? Empirical treatment. So native valve empirical treatment is with amoxicillin, but in the ward setting in NHSL or the other hospitals, you would have noticed that we use ceftriaxone. But you may consider adding low dose gentamicin. And if the patient is penicillin allergic or MRSA or severe sepsis, you might start the patient on vancomycin and low dose gentamicin. And if the valve is prosthetic, again you go for vancomycin low dose gentamicin combination. And what about native valve endocarditis caused by staph? Now here this scenario is different. See, native valve endocarditis, and you know the organism. Okay, you know staph. The culture has come as staph. In this case, you give flucloxacin plus genta. And again, penicillin allergic or MRSA, you give vancomycin and gentamicin. Okay. And prosthetic valve, staph positive. Flucloxacin plus rifampicin plus gentamicin. So for prosthetic valve, you add a rifampicin for the same staph. One more. If the patient is again the same story, see, penicillin allergic or MRSA, the same regime for prosthetic and native. What is different between prosthetic staph and native staph is the addition of rifampicin. So that's the basic difference. Okay, understood? And endocarditis caused by fully sensitive streptococci, that is viridans, you go for only benzyl penicillin. And if the patient is penicillin allergic, you go for vancomycin and low dose gentamicin. And if the endocarditis is caused by less sensitive streptococci, a resistant one, you go for benzyl penicillin and low dose gentamicin or vancomycin plus low dose genta. And penicillin allergic, again you go for vancomycin. Okay, that's usually they don't trouble you for this antibiotic regime. Go and read leisurely, you will understand. Okay. And what are the complications of endocarditis? This they do ask. So there are local and systemic complications. The local complications are perivalvular abscesses that might cause heart block. This is a famous question. If you get a first degree block, that means PR prolongation, you should suspect an aortic root abscess in an infective endocarditis patient. Okay, a common question. Heart block. There can be fistula, valve destruction, severe regurgitation, and heart failure. Heart failure is the commonest cause of death in IE. Again, a reasonably common MCQ. Heart failure is the commonest cause of death. And these were all local complications, but there are systemic complications as well. As I told you, septic emboli with metastatic abscesses. You get multiple splenic abscesses, brain abscesses, abscesses in the kidney, vertebral osteomyelitis, psoas sepsis, especially with left-sided endocarditis, because left-sided endocarditis will give rise to systemic emboli. Right-sided would give rise to septic pulmonary emboli. This is also a famous MCQ question. Pulmonary embolism can occur due to right-sided infective endocarditis, that is commonly the tricuspid valve. Okay, the vegetation from the tricuspid can dislodge and go into the pulmonary circulation. So there can be pulmonary embolisms, pulmonary infarcts, abscesses, pleural effusion, empyema, very rarely pneumothorax. So the whole spectrum of lung diseases can occur. And neurological disorders. So they can get cerebral abscesses, infarcts, mycotic aneurysms, hemorrhages, SH. So these are common, favorite topic for the examiners to ask. The third set of neurological complications, those are commonly asked. And renal complications, septic emboli with abscesses, immune glomerulonephritis. What is the commonest type of glomerulonephritis you get with infective endocarditis? It's membranoproliferative glomerulonephritis. And renal involvement can be due to drug as well. The drugs we use, Vanco can cause ATN, Genta can cause ATN, cephalosporins can cause tubular interstitial nephritis, and sepsis-induced pre-renal failure and cardiorenal syndromes are very rare. So usually renal involvement is due to glomerulonephritis or septic abscesses. And you can get musculoskeletal, as I told you, vertebral osteomyelitis, septic arthritis, psoas sepsis, anything. Usually the axial skeleton and multiple joints are involved when you get septic arthritis due to infective endocarditis. And then you can get pulmonary complications that I spoke about earlier. Sorry, it's a repetition. And coronary embolism, very rare. You won't be asked, but the postgraduate trainees are asked. You can get MI due to infective endocarditis, surprisingly. That is when you have a coronary emboli. Okay. Anyway, the other common question they do ask is, when do we need to go for surgery? That's again a famous area of, favorite topic for the examiners to ask, because when do you refer them to the cardiothoracic team? So we do give antibiotic for everyone, but all of the infective endocarditis patient doesn't need treatment with surgery. Okay. So complications of infective endocarditis, paravalvular abscesses, of course, you have to refer to the cardiothoracic team, fistulation, severe valvular destruction, refractory heart failure. Mind you, heart failure with infective endocarditis per se is not an indication for surgery. It should be a refractory failure, not responding to furosemide. Recurrent emboli, not one episode, recurrent emboli is a risk factor for heart failure. And organisms. I mean, certain organisms, fungal endocarditis, if the organism is multi-drug resistant or if there are large vegetation. On the left side, vegetation more than 10 millimeters is considered large. On the right side, it's 20. But don't worry, you don't need to memorize for the undergraduate curriculum. But there are these common false terms they give is unavailability of antibiotic. So you live in a peripheral hospital, you don't have antibiotic, do you go for surgery? No. Unavailability of antibiotic is not an indication for surgery. This is a common false term which circulates in the pool of undergraduate exams. So whether it's for ERPM or state or KDU, that is a common stem. That is wrong. Fungal endocarditis, yes. Large vegetation, yes. Multi-drug resistant, yes. Don't memorize the size. That's for the PG trainees. What are the poor prognostic factors in IE? Again, not very common in the undergraduate curriculum, but few occasionally asked. But for PG trainees, they should ask. Old age, diabetes, staph endocarditis carries a poor prognosis. At least if you can't memorize this list, at least memorize this. Staph endocarditis is a poor prognostic factor. Low albumin, low complements, heart failure, large vegetation, embolic complications. These are all poor prognostic factors. It's just basically a list to memorize. And who needs prophylaxis for endocarditis? It's a controversial topic. Okay, those days all the procedures warranted infective endocarditis. Now what they say is if you have a predisposing heart condition, that is a high risk condition like the second one, the prosthetic valve or intracardiac devices, then, and if you are going for an invasive procedure, I mean dental extraction or scoping with biopsies, then you need. For example, for a mitral regurgitation patient who is not going for a, I mean, just going for enamel cleaning, you don't need a prophylaxis. Okay. And colonoscopy with a mitral regurgitation doesn't need a prophylaxis. But if you are going for a colonoscopy and biopsy, you need it. But there are controversies between the guidelines. Don't even worry. These are past questions. You can go through it. Any questions? Do you need to ask anything? Nadun, clear?
Yes.